Now, switching between drugs, how do you switch a patient who's not doing well? Well, there's different types of not doing well. And the first principle is all other drugs may work when one drug fails. And the primary failure of any drug means you change the class. If they immediately don't respond to the first drug, like ixekizumab, you want to go to a different class, like an IL-23. And if there's a secondary failure of a drug, the patient does well on ixekizumab and like 24 to 48 weeks later stops doing well, then you stay within that class because they probably respond to the MOA, but for whatever reason, that particular drug pooped out. So if ixekizumab fails a year in, switch to bimekizumab or secukinumab. You'll probably get success. So primary failure, early, no response, switch class. Secondary failure, late lack of response, stay within class. And always consider psoriatic arthritis efficacy. The loss of skin response while retaining psoriatic arthritis control means stay within the class. Maybe you just need more potency on the skin side. For example, a secukinumab skin failure with good joints control, convert that patient to bimekizumab, another IL-17 pathway blocker with more potency in the skin, and you'll get the skin control with the joints. Let's say you have good skin response, but bad joints control. Switch the class, add a second drug. For example, you have good response to the skin with an IL-23, but the joints are doing poorly. Switch to an IL-17, which covers both the skin and the joints. Or you can add a apremilast to the IL-23, or deucravacitinib, or methotrexate. Combination therapy should not be feared. It should be viewed as a pathway to success in your toughest patients.